Okay, so I think we should go through look at some ECGs. I got this ECG from Motion yesterday. I want do you have polls or somebody, if somebody could from the audience would come and explain this ECG to me. So this is a 7-month-old baby with recurrent syncope.
We'd like to have some participants who are interested. Please raise the hand.
And also we'll give the poll and then one participant if could join us.
Neha, please keep the poll for 10 seconds, 15 seconds.
Okay.
So just after 15 seconds, the poll will close and we'll have the result. Okay.
So we have two diagnoses, sinus rhythm with 3-to-1 conduction and complete heart block. Anybody from the audience would like to join me?
Sudhir.
Yes, we have Mr. Sudhir. Mr. Sudhir, can you please, Dr. Sudhir, can you please give some explanation to this ECG?
So I'll let Sudhir come up, but the reason I put this 3-to-1 conduction and whoever answered 3-to-1 conduction makes some sense. If we look at my, where is my pointer? My pointer here, there is a P wave, third one conducted. However, if you look backward, there is no such constant relation. So if you look at the last RR interval, it looks like 3-to-1 conduction. And that's where you look at carefully throughout the long rhythm strip. It's complete heart block. So no question about it. My question is, why is this patient passing out? What is the question? Sudhir or whoever wants to answer this. And then we'll go, I'm going to go to the next ECG.
Sir, there may be two explanations. If I'm, sir. One is that because of the baby is only 7-month-old.
Yes.
So he needs very high rate of ventricular rate for his body requirements.
Okay.
But at his age or at heart age, the heart rate is too low. So the perfusion or the due to hypoperfusion, he may pass out. He or she may pass out.
So you are saying that this heart rate of 42 can make the person pass out?
For the 7-month-old, because the age is only 7 months.
Okay.
The rate
Any
is
other
too low.
explanation? Any other?
And another explanation might be because of the presence of this too low heart rate, the compensatory mechanism might put some ectopic focus to take command and resulting in SVT or VT, which might result in passing out of the baby.
And anybody else? So look at this. The QRS is narrow. So that means it's a junctional escape rhythm. One possibility is that why do patients pass out? Because they have no contraction at all. So there'll be a period where there is no heartbeat at all and patient pass. It is unlikely that somebody will be passing out at the heart rate of 42. But one of the things that has happened here, look at the QT interval is very long. It is 600 milliseconds. And if we correct it, even after correction, it will be long. So this is the same patient. Next ECG, this is a Holter monitor. And as you can see, I'm going to look at these two ECGs. Look at this QRS complex, long QT, and then there is 3-beat. And then you can see here, this is the strip and this is the expanded one. You can see that there are PVCs and then the patient goes into this polymorphic VT and it stops. And this was the reason that patient was passing. As Tushar mentioned, that some kind of ventricular arrhythmia. And this is another episode. So all these episodes. So it was not the complete heart block which made the child pass out. These were episodes of torsade that made the. Please remember, the first thing torsade was described was in complete heart block patient, not in electrolyte abnormal. That came later on. Question is, what are you going to do with this patient? Are you going to put a pacemaker in or a defibrillator in?
Sir, as this is the Brady induced case,
Yes,
so putting a simple pacemaker will solve the problem. And
perfect.
giving the okay.
Yes. So no
And
question. So this is
one key concept for the audience, because basically when there's a QT is prolonged, and most commonly what happens is bradycardia induced VT. That's why we need to prevent the bradycardia, so that will prevent future problem. That's the pacemaker I think that Tushar has mentioned. That would be the right answer.
yeah. So the pacemaker, and this, I'll definitely do an echo, but in a 7-month-old baby, even if patient is ICD, you can't really do it. But even if this patient was adult person, 60-year-old with this ECG, if the echo shows normal left ventricular function, I'll just put a pacemaker in. And that is the answer to this question. Hafiz, any comment on it?
Any reversible underlying causes?
Yes.
No, this patient, everything was normal. This is, he was born with this. This is congenital complete heart block.
Congenital, like a mom lupus or something?
I don't know the story. No,
Okay.
I don't know the story, but this is the narrow QRS escape. So this is, but we have seen this similar ECG in adults also. But the reason I mentioned the defibrillator is that just because patient went into VF doesn't mean that this patient needs a defibrillator. This is bradycardia induced torsade. And as Hafiz mentioned, if there is no other cause, and most of them reversible cause, should be treated, and just put a pacemaker in this person.
So in the adult, maybe it is relevant to mention, Rafique bhai, sometimes we see this bradycardia dependent long QT and torsade, and there is acquired causes, electrolyte imbalance, psychotic meds. We try to give isoprenaline and then give an overdrive pace by time, and then QT becomes shorter, and then the torsade goes away.
Absolutely. I mean, this is an interesting thing about medicine, that to give a treatment is an easier decision, a harder decision to have the courage not to give a treatment. And that's where our specialty comes in. You discuss with the patient, you explain what we are doing, that look, you do not need it. I had a patient, 18-year-old kid with hypokalemia, and came with VF. And the push was this patient needs the ICD. But I said no. And I sent a second opinion to Johns Hopkins, to Hugh Calkins, and he said, Rafique, I'm glad that you said no ICD, because this patient has a potassium of 2.1, and you correct the abnormality and you take care of that problem. So we have a little time.
Sure, sir.
Okay, I'm going to do a few questions. Somebody, let's give a poll.
Yes, sir. Sir, is this the ECG?
Yes.
Okay. Kamrul bhai, please arrange the poll and give it for 10 seconds. Okay, we have the poll, sir.
Okay. So 5 people answered. 3 said normal ECG, and 1 said sinus rhythm with left atrial enlargement, and other was normal, and 1 said sinus rhythm with left ventricular hypertrophy. So yeah, these are all choices, but obviously, if you suddenly look at this ECG, what does it look like? Looks like a normal ECG. Initially, if you look at 3 and AVF, looks like leftward, but it lead 2 is positive. So, and there is no evidence of left atrial enlargement. Look at V1, P wave is normal. P wave duration may look a little wide, but here in V1, it doesn't fulfill the criteria. So this is a normal ECG.
So only thing that can distract is that the appearance of the T wave.
Yes.
Especially in V4.
In V4?
V4 and lead 2.
Yes, so that's what
peaking.
it is. Exactly, but look at the duration. You see, that's where, Athar mentioned something. Just don't go by the gut feeling, measure it. So look at the other leads also. Look at lead V1. It looks positive, negative, duration is fine. There is some sliding, sometimes P wave duration. So yes, it can be, but overall, this is a normal ECG.
Yes, sir. Definitely.
Okay, so this one.
Kamal bhai, give the poll and keep it for 15 seconds.
Okay. So I like
Tied up
yeah, it's
between 2 and
actually
3.
between 2 and 3. Okay. So
2
nobody
and
said
3. Oh, let me understand this. Old septal. But Rafique bhai, I like your EKG, but I like more your options, because you are simply challenging that. What is the criteria for left atrial enlargement? What is the criteria for right atrial enlargement? What is the criteria for our right ventricular hypertrophy? I like that. So if it is a 2, what is the criteria for old septal MI in the presence of right bundle?
okay, so I'm going to bring this up. Hafiz, you are on the right track. So let's discuss this. So axis is rightward axis. No question about it. Because I put this one, the way I did it is lead 1 is negative, so it's on this side. And then lead 3 is, lead AVF is positive, so it's between 0 and 90. And then if you look at lead 2, it's slightly positive, so it's between here, so it's a right axis. Now I will show you what Hafiz mentioned. What looked like a septal MI is actually not. It does. First of all, there is a small R wave. Even if there is no R wave, that Q wave, Hafiz did not fulfill the criteria of septal MI.
Yeah,
it's too narrow. So that's one part. And look at this P wave. I have enlarged it. You can see it is 3 small square, which is 0.3 millivolt. Anything about 0.25 is right atrial enlargement. Look at this lead V1 enlarged, and it is about a box and deeper than 1 box. So it is biatrial enlargement. So as Hafiz said, I mean, we always have to think like that, that look at the alternatives. The question choices should not be random. And then look at the right ventricular hypertrophy criteria. More than 110 degrees, RS ratio in V1 more than 1, which is true. R in V1 more than 0.7 millivolt, which is true, is about 1 millivolt. And then QR in V1, if this was a Q wave, that would have supported right ventricular hypertrophy. And it doesn't fulfill. So we are fulfilling all these criteria. And then, of course, we have differential diagnosis, isolated LVH, WPW, COPD, true posterior infarct. We have to, right bundle doesn't fit in here because the QRS is narrow. If look at this, when I enlarged it, you see 1, 2, 2.5 box only, less than 20. So it's less than 110 millisecond, 100 millisecond. So it's not wide QRS. So it doesn't fulfill right bundle branch block. So this is, my diagnosis was basically sinus rhythm, biatrial enlargement with right ventricular
hypertrophy. Yes.
Yeah.
Number 4, sir.
Yes.
Sir, Assalamualaikum, sir.
Yes.
Can we put another differential diagnosis of previous ECG, that right axis 110 degree with RVH, tall P. Can we explain with ASD with severe pulmonary hypertension?
Yes, I mean, so that's where comes the physiology. Narrow mind is getting into the physiology. Now, how old is the patient? 34-year-old.
Underlying cause.
Yeah, and it's a possibility. Yes, no question.
But that is a possibility. But I tell you, if you bring the ASD, at least for exam purposes, you need to show that there is a right bundle. If
Yes.
only right, because this is the expectation in the exam. I mean, this is like a driving test. Right bundle and then left axis, ostium primum, right bundle with right axis is ostium secundum. So
That's it's a board question, right, Hafiz?
Both questions. So it's like a D-Jack reaction, but it is possible for the right ventricular hypertrophy to be with that. Yeah, sure. And then pulmonary hypertension, COPD also possible. But
Yeah.
Fantastic EKG. I wanted to add one thing, Rafique bhai.
Yes.
Even if you think that there is a Q wave in V1, right?
Yes.
This EKG is so good, there is nothing in the V2, V3. I mean, imagine a septal Q, but there is only one lead. So I think it is a home run to ignore that.
Yes. Yes. There's no question about it. So thank you. But as Naro mentioned, that we need to keep all this in mind. I mean, unfortunately, for adult cardiologists, we always try to ignore the right side of the heart. And Naruma is a pediatrician, of course, she will pay attention to this. How about this one?
Kamrul bhai, keep the poll ready and keep the poll for 10 seconds for this ECG.
So I tell the ER physician one thing, Rafique bhai.
Mhm.
The uglier the EKG, less likely ischemia. Don't call me. The uglier it is, the uglier the EKG, the less likely is coronary.
Okay, I think we accept both, right? C and D, anybody comment on this? So the choices are C and D. Well, I mean, I mentioned that reverse ROA progression. At one time I thought, is it possible that somebody swapped the lead? V1, V2, V3 became V4, V5, V6. It's a possibility.
That is very, very remote, because that is very creative to do.
Yes. Second issue is that if you look at the P wave in V1, it's biphasic.
Yeah.
If I had swapped this lead so much, then it will not be like this. P wave will be upright in this lead. So this is not a lead swap or anything. So I think this is a good answers. So here,
I'm dying to know what is the underlying cardiac issue.
well, unfortunately, I did not. This is the 2003 ECG. So I did not write. So you look at this QR pattern in V1, which is consistent with right ventricular hypertrophy, V6 4-hour progression. And so again, the criteria, I have put it, the criteria, all those criteria. Remember this, I mean, a lot of times we don't remember, but you can put this in your iPhone. So what you do, you look at ECG, you think that this is right ventricular hypertrophy, then we confirm your diagnosis. That yes, my numbers are correct. There's no need this day and age to remember all these numbers, right, Hafiz? You can't remember. Yeah. You can just pull it up, but you have to suspect. You don't ignore the ECG. You just look at it. Now the question would be, the other question is, some of them have clinical relevance, some of them don't. But even then, understanding it exercises our brain. One of the things I'm going to, I think, probably stop after this. One of the things that why did Atar give this lecture of physiological basis? I think theory of any medicine, any science is important. Theory gives rise to the future, and that's where Hafiz comes in. I am a practical guy. Hafiz goes into realm of theoretical of theory. Theory is important because theory gives the future, and applied science gives the present. So understanding physiology, understanding mechanism is so important in this. I think we're going to.
I have a question, sir. Previous
Yes.
ECG. So
Yes.
why poor progression or loss of height of ROA before to V6?
What
If we
okay.
think the right ventricular hypertrophy or right ventricular mass, right ventricular hypertrophy due to RV hypertrophy, and
Yes. So right ventricular hypertrophy can rotate the heart leftward.
okay.
So if
So-
this patient, if we had put a like V7, V8, V9, it ROA will again get better, bigger.
Now LV mass is okay. LV mass is normal. So here height of ROA in B4, B5, B6 usually having normal. I think.
Yes.
Yeah.
Why not?
But
Why not?
This can be consistent with primary pulmonary hypertension. This can be consistent with pulmonary stenosis. It can be even consistent with ASD with severe pulmonary hypertension and RVH. And
Yes.
that all, I mean, the right heart is the
Right.
big issue here.
well, Govinda,
Yes,
your
sir.
point is very valid. I understand what you are asking. What is happening? The place where I have put the V6, left ventricle is
Okay.
no longer there because right ventricle has
Rotate.
pushed it more,
Yeah.
to the left. So if
Yes,
I
sir.
had put V7, V8, V9, then you will
Yes, sir.
find the left ventricular signals.
Yes, sir. Yes, sir.
Yes.
Clear. Thank you.
And
sir.
this is not going to be dextrocardia.
Yeah.
No.
Yes, sir.
Not
One
going to
AVL
be.
is normal. One
Yes.
AVL.
Yes. All right. I think we should stop here. Right. Yeah, I think let's stop here. We're out of discussion, and thank you all for participating.
Rafique bhai, can I add one thing?
Yes, please.
I have learned over the years that the EP has a EP mind, but practically I request everybody to get your slide calipers out. When you have a bradycardia, then map the QRS and understand what is the mechanism of ventricular depolarization, and then understand the mechanism of atrial depolarization, and then relationship between atria and ventricle. That measurement eyeball sometimes doesn't work, because when we start measuring this, I think it makes a lot of sense.
To Hafiz, the day I stop using the caliper is the day my knowledge starts going down, because then I rely on my imagination. So you're absolutely right. I mean, even to this day, when I sit down, when something is, even if it is obvious or not obvious, using a caliper is so important. If you don't have a caliper, take a piece of white paper and mark it. You can mark the QRS complexes, and that's how you can move back and forth. So it's so important. It is very, very important that you do the measurements. Thank you.
Thank you, sir. Thank you, sir, for your nice ECGs.
Whether they want to close the session or Atta?
Yes, sir. Chaudhary Hassan, Hafiz bhai.
আমি ঠিক আছি।
No, Hafiz bhai, actually, we are expecting you in the next session.
Sorry, sir, the electricity was out, so
জি বলেন।
In our roster, actually, you are the speaker on the next session. There is the that is the Sunday and next Sunday.
26th, sir.
No, 20,
Sorry, 25th, 25th of
24th.
September.
24th.
Okay, Abid bhai.
আচ্ছা
25th, sir. 25th.
20 minutes, তাই তো?
Sir, basically 30 minutes, then we discuss.
No, not 20 minutes. Actually, one day will be the basic and next day the clinical. The whole session is yours.
Yeah, okay.
Sir, one thing is, I like to ask the right atrial enlargement. In case of right atrial enlargement, is it mandatory all the leads POF is enlarged or fulfill the criteria, all the leads?
No, you cannot. You see, if you look at other leads, some of the leads are small.
Individual lead is important.
Mostly inferior
If it-
leads, and inferior leads shows is best.
Okay, thank you, sir.
Govinda, it's important that like
Sir.
coronary angiogram, the worst case presentation যেখানে stenosis বেশি দেখতে পাচ্ছ সেটাই তুমি ধরে নিবা।
জি স্যার।
এখানে তোমার ইনফিয়ার লিডে তোমার এক্সিট যদি চিন্তা করো কারেন্ট উপর থেকে নিচে আসতেছে, কাজে ইনফিয়ার লিডে যদি আমি রাইট এট্রিয়াল এনলার্জমেন্ট দেখতে পারি, দ্যাটস এনাফ। আর ইন জেনারেল দ্য শার্পনেস অফ দ্য পি ওয়েভ পিক, যদি পি ওয়েভটা খুব শার্প থাকে, এটা তোমার যদি অ্যামপ্লিটিউড কমও থাকে তুমি ধরে নেবে এটা রাইট এট্রিয়াল এনলার্জমেন্ট থাকার পসিবিলিটি বেশি।
জি স্যার, থ্যাংক ইউ।
আমি এই প্রসঙ্গে একটা ছোট্ট জিনিস বলি, সেটা হচ্ছে কি আমাদের এখানে যে ইসিজি পরীক্ষা হয় ওইখানে ওই ফাইন্ডিং এর পরে নির্ভর করে স্কোরিং হয়। তো সাধারণত রাইট এট্রিয়াল এনলার্জমেন্ট বা লেফট এট্রিয়াল এনলার্জমেন্ট ওয়েটেড স্কোর ইজ 1 মেবি 2 ম্যাক্সিমাম। মেইন হলো যে মানে হাইপারট্রফি বা যেটা মেইন একটা 10 টোটাল 10 দেখা গেলো যে এএসডি ওইটা হচ্ছে যে 9, আর রাইট এট্রিয়াল এনলার্জমেন্ট আর নট এনলার্জমেন্ট এটা কেউ মিস করলে ওটাতে মানে পেনাল্টি কম। সো উইচ মেক সেন্স। আর আমাদের এখানে আরেকটা জিনিস হলো যে যদি ইসিজি দিয়ে কেউ ফেল করে সে 99 পাইলেও লাভ নাই জেনারেল কার্ডিওলজিতে। ইসিজি তে ফেল মানে ফেল, ও তাকে আর কবর থেকে উঠানো যায় না।
এটা কিন্তু ভেরি ইম্পর্টেন্ট। আরেকটা জিনিস হাফিজ, আমাদের আমেরিকায় কোনো নেগেটিভ মার্কিং না, মাল্টিপল চয়েস, বাট এক্সেপ্ট ইসিজি কেউ যদি অ্যাকিউট এমআই মিস করে, কেউ যদি ভিএফ মিস করে, দ্যাট মিনস ইউ হ্যাভ কিলড এ পেশেন্ট and you will get -1. But that's the only few cases that is -1. Otherwise, rest of them are not.